We have multiple sclerosis, MS. Yeah, so we have well-defined plaques of demyelination with relative preservation of neuronal elements and inflammatory cell response. So we have well-defined plaques of demyelination. So demyelination is where the myelin is destroyed, the myelin sheath is destroyed, but there is relative preservation of neuronal elements. Yeah, so some of the neuronal elements like maybe the glial cells and so on are preserved. And then there is inflammation. So there will be neutrophils or there could even be chronic inflammation. So we have selective loss of myelin sheaths. So the myelin sheaths are basically the ones that are destroyed. Basically, when you talk of neuronal elements, things like the cell body, the axons, the dendrites are preserved to a great extent. It's mostly the myelin that is destroyed in multiple sclerosis. So episodes of demyelination occur in multiple different sites in the CNS. That is why when it's called multiple sclerosis, they tend to happen in multiple areas, many different sites in the central nervous system. That is the brain and the spinal cord, and even at different times. Yeah, so at different times, different areas, different sites, separated in place and time. Yeah, so places that are different places that are affected and even different at different times. So that is why we have the name multiple sclerosis. It is postulated there is an abnormal immunological reaction, possibly triggered by a viral infection resulting in focal myelin destruction. So this one will appear like an autoimmune disease. So there is production of maybe autoantibodies, or it is thought that there could be autoantibodies that selectively destroy the myelin. Yeah, and it is thought that one of the triggers could be viral infection. So nobody yet is sure. It's a postulation. Yeah, that this could be what could be causing the destruction of myelin sheath. Yeah, you can see there, you can have tumors, of course, within the brain. Yeah, which could be metastatic. So you can have metastatic tumors to the brain. Yeah, basically, when you talk of metastasis, it could come from anywhere. For example, even cancer of the prostate can actually metastasize to the brain, cancer of the bones, or any part of the body for that matter can actually spread to the brain and can affect any part of the brain. So when you talk of course intracranial tumors, anatomic distribution, that is where they are found. For example, you can have a tumor that is arising from the meninges. We call it meningioma. And you can see what will happen is arising from the meninges. For example, it's arising from the dura mater. It will tend to press into the brain. It grows, not necessarily infiltrating the brain, but it compresses on the brain. That is causing pressure on the brain. Then we can have glioma. You know, gliosis, we talk about gliosis. For example, those glial cells can develop a tumor. And so you can have a glioma, and that will tend to be within the brain substance itself. Pineal gland can develop a tumor called pineoloma. You can have a tumor that is arising from the astrocytes. So you have astrocytoma, more common in the medulla, in the cerebellum, and also medulloblastoma. You can have a medulloblastoma. You can have a ependymoma. You can see this one will be arising from the ventricle. You remember the ventricles? We have the ependymal cells that actually produce the CSF. So we can have ependymoma. You can have acoustic neuroma. Yeah, pituitary adenoma, that is in the pituitary gland, craniopharyngioma. So those are some of the places where we can have tumors arising. Some of them will be benign tumors, some will be malignant tumors. But of course, generally tumors within the brain, all of them, whether benign or malignant, they tend to cause symptoms, especially because of pressure. Because remember, the brain or the skull is a very small area and it's a restricted area. It has no ability to expand. Yeah, so any tumor will cause increased intracranial pressure, and so it will cause symptoms. We have astrocytoma. And it can be graded from grade 1, which is the slowest, to grade 4, which is most aggressive. This is what people call glioblastoma. So astrocytoma can be benign, and most of them, by the time you reach into grade 4, it's aggressive or it's malignant. It has varied histological features, may arise anywhere in the cerebral hemispheres, brainstem, so it can arise in the hemispheres, because wherever the astrocytes are, those cells, those glial cells are, it can arise there in the hemispheres, in the brainstem, in the cerebellum, or even it can arise in the spinal cord. And it can present in all age groups. So this one are not restricted to a specific age group. It can occur in the young, in the old. So we have glioblastoma, as we say, basically we look at astrocytoma grade 4, that is one of the highest grade. We call it a glioblastoma, composed of highly atypical glial cells of varying sizes. There will be necrosis, that is dead, the cells will die there, the neurons will be dead there, there will be necrosis, the high cellularity, so there will be increased mitotic activity. There will be vascular proliferation, that is blood vessels around there increase. There is an increase in number of small blood vessels, so there is vascular proliferation. And it has very poor prognosis. That is, if you have to have this kind of tumor, glioblastoma, maybe if you're talking of how long somebody can live, in 5 years, you probably will have people who have this disease, maybe most of them will be long dead because it has a very poor prognosis. So if you look at the features, there will be nuclear atypia. That is basically the nuclear will be different sizes, shapes, and so on. They will be atypical. There will be increased mitotic activity, so there's a lot of mitosis. So there will be a lot of cells in different stages. There will be cells that have maybe multiple nuclei. So there will be microvascular proliferation. Those are vessels. There is those very small blood vessels. There will be a lot of, they'll proliferate. That is increase in number. There will be necrosis, as we have said. That is just a diagram showing astrocytoma. The left is a diagram, the right will be a micrograph. So you see, mainly you will have tumor cells, you have necrosis, pleomorphism, you have mitosis, that's the increased mitosis, tubular network, and so on. Those are some of the features that you're likely to see. In glioblastoma, you're likely to see anaplastic cells, tumor cells. Anaplastic basically are cells that are not, they are poorly differentiated or not differentiated. So if you thought of something being anaplastic, means that it's not differentiated. It may not be differentiated at all. Those cells are not, and there will be necrosis in various areas within that particular tissue. Palisade arrangement, I think we talked about palisade arrangement in one of the tumors that we talked about, and vascular proliferation. That means there is increased in number of blood vessels within that area that is affected.